This is case number 1 from Madras Medical Mission, Chennai. So here we have severe PR in the patient, 42 years old female, underlying pathology for low, post intracardiac repair with transannular patch since the patient was 20 years of age. NIHA function was functional class was class 2. Having a history of dyspnea on assertion for 3 months, palpitations whatsoever, and then NT-proBNP is somehow slightly increased. ECG complete Ramadan branch block, duration of QRS was 160, and echo having severe PR and significant RV dysfunction. So next please, next slide please. Sorry, we're still fixing on your sound, but let me try to say to the audience first. Yeah, so in terms of the MRI, the patient has matching the endoscopic volume index 186, more than 160. Ejection fraction is somehow decreasing 35%, and cardiac CT looks as if we have the maximum diameter in the proximal is 31 millimeter, and the mid part is slightly larger than the proximal, and the distal, the largest diameter is about 37, and the length somehow 27 to 29 millimeters from cardiac CT. So next please. Okay, I'll try my best to interpret this, okay, Shiva? So on lateral projection, looks as if we have quite large dilated RVOT MPA. Looks as if we have a waist at the middle part of the MPA, and it's quite big anatomy on the lateral projection. Yeah, so proximal diameter 39, the mid 38, distal 37, and the length 29. And also he did balloon test interrogation, and the waist about 32 millimeter.
So what type of balloon is that?
I think it's a sizing balloon, right, Shiva?
Not.
Okay.
Okay.
Yeah,
okay.
Thank you. All right, so I'll try to read your mind. Okay, so this is probably the RAO cranial view. You put the wire onto the right left pulmonary artery in order to see and delineate the anatomy in different angulation. So it's quite broad bifurcation, and the proximal part 31 millimeter. The middle part is smaller than on lateral view, 28. Distal MPA 32, and the length 26. And here also the same diameter of the waist with the AG sizing balloon, 32 millimeter in the middle. Next please. And also he also did the LAO cranial, I think, yes. And so this most of the time trying to profile the bifurcation, and you can see it's separately you know, coming out between left and right. And again, the waist is in the middle. So here, the waist with the balloon is 29, slightly smaller than the other angulation, but from the angio, the mid part is 32.5.
Vorakan, why go cranial? Why not pure lateral?
Well, I think our LAO cranial, she was trying to see the bifurcation properly.
Yes, can you hear me?
Oh, now we blank.
Vorakan, can you hear me?
We lost.
Oh, we come back.
It's echoing back.
Yeah, I can hear you, but just like from Mars or Venus.
Sorry, are you able to hear me now, Vorakan?
Yeah, you shout, but we still cannot hear you well. So if somebody can increase the volume a bit.
Yeah, can Vikas increase the volume?
Yeah, much better.
Thank
Shiva,
you.
can you hear
Thanks,
us now?
Vorakan, for the nice opportunity that you gave us, and host and Jack as well. And thanks for reading our slides till now. I'll not waste my time. There is no coronary compression. If you look at all the volumes, all the diameters, it's somewhere the narrowest point was 32, but in few areas it was 34 to 36. I'll show you some more angiogram. Next PowerPoint picture. Dr. Adam was kind enough to give us some virtual reality reproduction of the outflow tract. And on this, he is now cropping the RVOT, and he is actually implanting a valve inside. According to his planning, he anticipated a 34 millimeter venous P valve. So this is his 34 millimeter venous P. If you look at that, there is some gap between the valve and the RVOT. So what we have planned earlier was 36 in order to get a good approximation of the valve against the outflow tract, while Adam's prediction was 34. We were pretty close. It's just a matter of couple of millimeters. Now let me show you live.
Shiva,
A few pictures I will show, and then I will take the discussions. This is, we had a right atrial mean pressure of 9 millimeters with A and V waves of 12 millimeters of mercury. And we had an RV pressure of around 32, and the pulmonary artery pressure was 32 by 4, quite ventricularized. And before I describe the angiogram, I am assisted by Ram Kishore, my associate, Dr. Pramod Sagar, who has been with me for many years, Sister Sharon, Dr. Alka at the imaging, Dr. Giridhar at the anesthesia end, and Prabhu, the radiographer, and Lalita Surya, a host of people working here on a Sunday morning. I'm going to show 3 angiograms today that was done today. We were not able to get the Lundrequist much more deeper than this position. I have a venous 24 French long braided sheath, something similar to a Gore dry seal, which has been just made, and this is a prototype. You can see that there is a little bit of kink. However, we have seen in our one previous experience that despite the kink, it works. So this is an angiogram with the Lundrequist in position, with the sheath in position, in RIO projection, which shows the separation of the LPA and RPA, quite pulsatile RPA and LPA, and sort of uniformly tubular outflow tract. I'll show a couple of more angios. LAO. Dr. Zahid was asking why LAO. Basically, this is to separate out the RPA and LPA. So this is in LAO projection. Again, a very pulsatile outflow tract, which is giving a large dimensions of the pulmonary artery in systole and little smaller in diastole. Third is lateral. So in the lateral view was quite large. The reason why we put the marker pigtail on the Lundrequist was for little bit more accurate measurements. Show the measurements, please. So this is on LAO projection. We were getting around 28 in the mid MPA. At the annular level, 32. Distal MPA, 33. However, in the lateral, it is very large. Show the lateral. So lateral, the distal main pulmonary artery is 36. The mid MPA is 40. And the proximal RVOT is 41. It is likely that the thick sheath and the thick wire are tenting the outflow tract superiorly, so that the LAO projections are smaller and the lateral projections are larger. It's anteroposteriorly elongated. Show the RAO dimensions as well. So this is 33 at the distal, 28 at the mid portion, 32 at the proximal. We have in all the places around 31 millimeter length. Varakan, I am now free to take your questions.
Yeah, so hit please if you have a question.
No, I think keep going. I agree with your measurements. I was just
Zahid,
wondering, but
your voice
you
is
were
very
saying,
faint,
Doctor-
Zahid. Can you please increase the audio?
Sure. Can you
Yes.
hear us? Yeah. For me, one thing I have missed was the when you do balloon testing. I mean interrogation. Does that balloon moving or just fixing?
It was towards the end of the balloon inflation, it was fixed, indicating
Okay. Yeah,
there is
I've
no
learned from
residual
the
flow.
previous people.
And second is the patient was deeply hypotensive.
Thank you. Well, I've learned from the venous people that once you have a balloon which is completely fixed, so you may add up to just 22 millimeter, larger than that diameter. If it's still moving, then at least 4 to 6.
Yeah,
Shiva,
it was
let
not,
me ask you, can you hear me?
it was initially moving, but when we were inflating finally, it was not moving much.
Thank you.
Now, about the
Another?
size of the valve, I'm sure indication will not be questioned because RV is very large. She's symptomatic, there is RV dysfunction. So the indication is not the problem. The only thing is
Yeah.
the lateral view dimensions are quite large. Is it acceptable for a 36 valve or is it larger than that? Show the lateral view measurement, lateral view measure. Here is where we got the largest dimensions. But I feel that it is anteroposteriorly stretched by the stiff guide wire and the stiff sheath. What is your opinion, Varakan?
Yeah, I do agree with you. 36 by 25. You know, I think there's plenty of room distally and proximally. And of course,
Varakan,
I would go
36 by
for
30
what
we
you're
are
doing.
planning because most of the time our outflow tract was 30.
Well, again, I think 36 should be good for this particular case. And I try to oversize at least 4 millimeter for that waist because it's so expansive distally and proximally, Shiva. And well, LPA deployment should be good also. For the sheath, I'm quite naive on this one, but to me it looks quite very easily to get kinks. So I may be quite careful when trying to pass on that kinks, but we'll see.
Yeah, so now we are at that acid
Please,
test
Adam.
now.
Sorry, Shiva. Adam has a question or comment.
Yeah, I have the comments about the simulation that we did. It is always given at the given phase of examination. It was the best systolic image, which is not the widest diameter really. So what the simulation requires in such cases is what Fuok was saying, the functional study with the whole cardiac cycle, because you can easily underestimate the sizes. And I truly agree now with what Shiva was showing on angios.
So there was discrepancy of 2 millimeters when you showed it, right? So that was, so you do it in, we do that at mid-systole to set the maximum diameter, right?
Yeah.
The first 30% of the systole, you know.
Yeah, it is not pure systolic image. Usually this is very, very mobile and you need all the phases to see precisely where the diameter is the widest. And that's why there was discrepancy, I think. And of course the most important are the angiographic measurements.
And work on, I mean, this advancing the sheath and increasing the anterior posterior diameter, would that change the size of the valve that you will use?
You mean the sheath?
Yeah, remember he said that when you put the sheath in, the anterior posterior dimensions increase.
I think I rely on the waist.
Huh?
I will rely on the waist.
That's the key I was saying.
Yeah,
so
I think that's the key.
So why would you measure?
You can make it like more, larger, bigger. But unless until the waist is there and then fixed, I think that's fine. For this, I think I will go for 36 as we sit, as I say.
And so the criteria that you use to let's say you go by 4 millimeters from the maximum waist? What
for this particular case, because proximally, distally is so expansive, and it shows that it can be more expansible, even up to 40. So that's why I have to rely on that waist only. So if the balloon interrogation is the sizing balloon doesn't move at all, then I may trust on that. But if you have to have more confidence, you may use something like the PTSX balloon, which is good for the balloon expandable valve, for example, sapien. And so with that, if we still can see the waist with a 40 millimeter balloon, I think that also gives a confidence that that waist is strong enough to hold.
Okay.
Yeah.
Varakan, I saw you never use a long sheath inside the pulmonary artery before the advanced valve. And with the measures before pushing the long sheath, did you use how much did you how big you use the valve? Did you change your idea before and after?
Well, I have very limited experience, to be honest with you. But again, I'll purely mainly rely on the balloon interrogation rather than this sensitivity from the sheath. But this is a good point, Jin, that you made. Shiva.
Yes.
So what do you think about the question that PA is very more expansile with the sheath in. Should we
Yeah,
oversize it more, or should we just keep it like that?
Okay, I will explain to you. In the CT scan, it was a little oval. However, the lateral view angiogram, not only with the straight sheath now, even in our diagnostic picture earlier, we were touching around 37 millimeters on the lateral view, which indicates anteroposteriorly the outflow tract was longer. But on a shallow RAO and a shallow LAO cranial, our RAO was around 37 and LAO was somewhere around 40. In that frames, we were getting little less, 32. So I feel that it is anteroposteriorly oval outflow tract, which is reasonably like natural to think that it's a transannular patch, native outflow tract. I mean, it's not always rigidly circular. We have come across this on few occasions, Varakan, where there is a disparity between one and the other view, orthogonal views, by 3 to 4 millimeters. It was not very surprised.
Yeah. So please, if you can keep.
So I will show you the sheath crossing.
Going.
Show the previous picture. No, don't go so much. Show the sheath, the kink in the sheath when we crossed. Yeah, next picture. This is the sheath gearing part. Next picture. Next.
Yeah,
Show the valve how it is manipulating the kink.
Yeah.
Yeah. So here you can see that it is with a little bit of push we were able to get the sheath across the kink. So I would rather say the kink was not hurting us a lot. Next picture.
Can we? Yeah, Shiva. Can we see the? Okay, lateral.
Ahmed, at this point I have not done a lateral. What I am planning to do is to open the LPA flare and then go to the lateral.
Monoplane?
Ahmed?
Is it monoplane? Shiva?
Yeah.
Yeah, single plane.
Almost
excuse me,
99% of the
that
labs
it was-
in India are monoplane.
Yeah. I think this is the best position. Yeah, this is the best position. No need to go to lateral.
Oh, thank you. You make life easier,
Yeah,
Ahmed.
I thought that it is biplane. So.
There are only 2 or 3 labs in the whole country which are biplane. So now we are opening up the distal LPA snare. It's a little twisted valve at that position. I will see how it opens. Yeah, it's now opening better. Okay. At this point, little bit more. Now we'll stop it there. I'll make another picture. Ready?
Very critical position.
Okay, I am quite deep.
Come back.
So now at this point, I'm going to advance the wire and get the valve a little bit below. Leave it.
Yeah, excuse me. I think.
Yes.
To me, it looks too high.
Overestimation.
Varakan, does it look too high to you, or is it?
Well, it's a bit
RVOT
deep, but I think he's coming back.
Do they use 10 millimeter
So now give another injection.
calibration?
Okay, I am the distal flare. The gold markers are at the LPA origin now. I will open a little bit more for the flare to open up, and then I will adjust further. So I am keeping my wire and my sheath rigid while Pramod is now opening out a little bit more. Ramkishore is controlling the proximal groin sheath. We can come up to 2/3 and then stop. Stop here. So, ready for another angiogram? I'm still a little bit inside. So I'll just drop the valve a little bit inside.
That's enough, I think.
Inject here.
Looks better now, I think. So
Yeah.
Yeah. So now Pramod is opening a little bit more.
Yeah.
Now once again, my
you
sheath
happy with
is
this?
there. So I'll pull back my sheath a little bit. Hold both together.
Yeah.
Thank you.
Need to keep pushing a little bit.
Okay. So now open up to the distal gold marker.
Yeah, but probably not go beyond this before you open
Okay.
more.
Hold it there. So ready for an angiogram?
Please.
Yes, I will. I'm now trying to push the guide wire. I think it
Shiva,
will fall back.
If you
Let
open
me
the valve
let
a
me
bit more.
see one more angiogram. Angio. Okay. Now I'll maintain a forward push. I think once I open the valve should realign itself. What do you think, Varakan?
I think so. I think so. Sisi, you happy with this?
I think so, but need to keep pushing the system a little bit
Yeah.
because
Yeah, I will do that. Is
quite
it
Not
low.
allow
super
the
or
system
CC?
to come down even further.
Yeah. Keep opening. 1 second. I'll get the sheath open. Yeah. Keep. Yeah. 1 second. 1 second. 1 second. Now that's a good position, I think. Inject ready.
One more angio, please.
Okay. See now probably I will not give a forward push because I have started opening in the distal outflow tract. We have to remember that this distal MPA was much larger, 37 to 38. So I will load a little bit more contrast in the injection. Varakan, what do you think about this last angiogram?
Yeah, I think somehow the valve is a little bit distal. But at the moment, if I were you, I may try to keep pushing the wire a bit in order to allow the flare to come back just a few millimeters.
Yeah.
I think it is oversized there. What do you think, Varakan?
Oversized by what,
Oversized,
Varakan? Ahmed, is it the length?
I don't think it's oversized, but actually the valve is not aligned with the
I think
RVOT
once
right
you
now.
release it, let me ask you a
It
question.
will
I have now used
align
this.
back.
Yeah, Sissy, do you
Once
think
you
that
release it,
the
will it
moment
not
I release the distal flare, it will fling back and then it will get opposed? You see that the inner
this
portion
is
of the
my
annulus is in
expectation.
line with the marker. Actually, the proximal gold markers are aligned with the annulus now. So the valve is
At
getting
this
restrained
time,
towards the
retrieval?
RV inflow. The moment you open out, it will spring back into the natural alignment. I was listening to Ahmed where he was mentioning it is oversized by length or oversized by diameter. Ahmed?
Well, to me, I don't think this is oversizing.
I think it is oversized. Yeah.
So
In my
is it in
opinion.
diameter or length?
I wonder about this at this stage for learning. Yeah, can you retrieve the valve
Shiva.
complete out
So, hey, let me ask
for
a
learning,
tech-
not
Sorry.
suggestion?
No, no.
I'm not
Let me
able
ask
to
a
get your
technical
question, Ahmed.
Yeah, not the suggestion, only for learning. Technical question.
Ask.
Yeah, can we retrieve the valve at this stage completely into the sheath?
Can you recapture the valve now?
It should be possible,
that
but
you
I don't
need
want to
to.
do it.
No, I'm not saying you
No,
should
no,
do
no.
it. His question is it recapturable when it's
We have
this much?
done it at this position. I mean, even a little bit more distal. You now see that the proximal flare, I am 1/3 released. 2/3 is still in constrained. In one of the patients, we had 50% of the distal flare at the golden ring, and the whole valve dropped into the right ventricle. And I was able to recapture it completely with a 24 French long Cook flexor sheath. not this venous sheath, but the Cook flexor sheath.
So Shiva, the technical question is, at what point you think is not recapturable?
At this position, I think it is possible. Right now,
Okay.
I will show you the present cine. At this position, it should be able to recapture. I'll just, for the sake of showing, I will move the sheath inside.
Sure. I don't think anybody wants you to recapture it. I think.
Can you see that I moved it inside?
Right. Thank you very much.
But I don't want to do anything further.
Okay.
So now,
I think deploy it here.
Maybe
can you make one more angiogram?
pushing the wire and then.
Yeah, I'm going to make one more angio here.
Please. Okay, so
I think once the valve springs, the
I think so.
the other valve will fall down. But anyhow, let me try to see, push the wire and see whether. Yeah, I made further
not
movement.
much.
Yeah.
Yeah.
Now Pramod, make
I
forward.
think this is the place.
Yeah.
I think
keep opening.
if you release the rest when the valve align with the RVOT, then the flare will go back to the RPA by itself.
I agree with CC.
Shiva,
Yeah.
angio here, just a few angio, please.
Angio. Angio.
Yes.
Lovely.
Okay.
I think this
Now-
is the place.
Okay. Now further rotate.
Slowly.
Rotate.
No need to rush.
Rotate.
Could you?
Okay. Now give one
See,
more
what do you
angiogram.
think now?
Actually, my pigtail is outside, but I will just see. Ready?
Yeah.
Okay. Actually, the pigtail is paravalvar. So I will now take out the pigtail. Give me a thermo wire.
Your catheter is stuck there?
No. I see. I'm now only going to try to remove.
Yeah, just
I wanted to see the position at that level. I will now take it out and then reach.
Shiva, is this catheter easy to pull back?
Yeah.
Okay.
I have come out, Sahid.
Pushing the wire.
Oh, it's learning purpose for everybody.
I'll now try to go inside the valve.
okay. Now we can get more beautiful angio here.
Shiva, do you think the middle part of the valve is 36 millimeters? I don't think.
I will measure, Ahmed. I will measure and show you. Right now, I am intending to just get it inside and confirm that my RPA is open.
Go to the lateral and then you can measure with pigtail with marker, calibration pigtail.
I'll get you. I'll get you that. Aspirate. My first intention is to ensure that RPA is fully open. The alignment seems to be okay to me here. We can also see that the two eyes have come out. You are fully open. Ready? Valve is functioning well, and the two eyes are fully released. So
Yep.
what I'm going to do is, I'm going to withdraw the whole system. At this point, sometimes what happens is, there is an infolding. Can you see that there is an infolding? See that there was an infolding and it got set right. I will show you that cine once again.
We
Can you
cannot
show that?
see it very well
See
here.
that infolding at somewhere around 3 o'clock. Show that first picture again. Stop. Go back 2 frames. 2 frames back. Okay, I'm now taking out the delivery system. Can you show me? Okay, now get me the marker picture. Get me the marker picture. Dr. Ahmed wanted a marker pictorial angiogram. I'll do that and I'll give a measurement. I also want a left coronary catheter. The alignment looks good, Varakan. What do you feel?
Say again, sorry.
The
He's asking you, what do
alignment
you
of the
think?
valve.
Well, I'm happy with this position, to be honest. But if you can help me do RV angio properly, so that would be great too.
Yeah, I'm giving 2 angios, one from the RV and one from the thermovire. I'll give you first pressures of distal and proximal. Okay, get both pressures up. Take it out. Where is the other pressure line? Pramod, connect the pressure line. Flush for 2 pressure lines. Get me the pressure flush.
Why
Open
don't
it,
you
it's
do
okay.
pullback? Such a miserable life right now. Why don't you just do a pullback? Pressure in the PA and then pull back.
Rather than pull back, I would like to have simultaneous pressures. Okay, I am having possibly some of the holes of the pigtail inside the RV. Let me see whether I can advance
Yeah,
it further.
I think so.
Yeah. Increase the speed. Make it in a more visible color. That blue, change it into red or green or something.
To any gradient?
No gradient. I'll enlarge the
Okay.
hemodynamics. Make the hemodynamics large.
Okay, now it's clear. So the diastolic looks good. I mean, the valve is competent, and the gradient is almost 0. Shiva.
Okay. Now I am going to do a angiogram distal. Get the ice blow.
And proximal too. Thank you.
Can you get me the angio ready? Ready for angiogram? I think maybe a couple of holes are across. Show in lateral view. Can you move that?
Shiva,
Show this
yeah, if you could
angiogram
do the
again.
lateral view because...
Yeah, we are going to the
Shiva,
lateral.
Yeah.
Lateral.
On this angiogram, your RPA looks good because the distal flare is uncovered, isn't it? So you're going to get good flow into it. And just confirm that on the lateral.
Yeah.
And
Shaq,
Shiva,
thanks for
just
coming.
to confirm, this is 25 millimeter length, right?
30.
Oh, 30. Okay, sorry for that. Yeah,
Ready
so
for
in
angio?
retrospect, this is probably a little bit longer, but I think that works.
Ready?
you see, that shows you the RPA end on almost, or not quite really, but it shows the distal flare nicely positioned.
Yeah, come to AP. Show the echo bigger. Echo big. Color. I will do one thing. I will take out this pigtail. So this is the intracardiac echo.
Oh.
I'll take out the pigtail so that the pigtail doesn't affect the images. Alka, you can do a echocardiogram.
There's a paravalvar leak with the ice. Shiva, are you trying to figure out paravalvar leak with the ice catheter?
Not the valvar. Okay, now we will see whether there is paravalvar also. Okay, run it by echo color.
What's the structure? What's the structure moving there?
Yeah, I'm also seeing what it is. I'm not finding a significant regurgitation. Take the color out, Alka. Can you disconnect the power cord there? Whether electrical artifacts.
Shiva, what is the structure moving back and
I am not understanding, Zahid. I don't know whether it is part of the valve. There is definitely something that
what's the ACT currently?
What was the ACT?
I'm seriously asking you. That is something that doesn't.
Actually, we gave. It's a 70-kilo lady. We gave 7,000 heparin, and the last ACT recorded 30 minutes before was 999. I mean, it's probably she's fully anticoagulated.
That doesn't sound right.
999 ACT.
Yeah.
I mean, it went to the upper limit and still it was running.
Probably we may repeat it again now.
We will do it now.
Try to remove
Get a repeat ACT, Pramod. See that there is something moving. However, I am not finding a leak. Can you put the color, Alka?
I'm not sure you need to figure out leak because you already ascertained by angiogram. So usually we do ice if there was a question about paravalvar leak after we put this. But I'm astonished about the structure.
Can you reduce the color gains? It is a lot of color around it. Enough.
Shiva, may
Yeah.
I say, in terms of the position of the valve, I think this
Little
is
bit
the
above,
perfect one.
at the level of valve.
This length and diameter. I have
At the level of
doubt on
valve.
that. I think you did a very great job. But for the something moving, I think we need
Little above.
to also think about how to deal with that. But likely that if we get proper ACT,
Little bit above.
I mean heparinization, and then we may remove the pigtail
Little bit below.
Carefully, and that's probably the best thing that we can do at the moment.
This is the pulse Doppler at the level of valve.
Compression study. Do you do coronary compression?
Well, after the valve or before?
No, before.
We have done it already.
Usually we find out from the CT scan beforehand. If the imaging people say to us the coronary is close by, then when we're doing balloon interrogation,
Alka, can you get
we would do an
thoracic
aortogram or selective coronary. But otherwise, if the CT scan nowadays shows coronaries are well away, then we don't.
But since this is balloon it's not balloon expandable valve.
Yeah.
So how much strength does it have that you?
Well, that's exactly the point, that even with the ASD sizing balloon that we use for interrogation, if that doesn't compress the coronaries, then there's no point in doing it after putting a venous valve in.
Gotcha.
So coronary angiogram.
Yes.
Shak, let me ask you that have you seen any coronary compression in native RVOT until yet?
So I've got one patient in whom, so it's not native RVOT, so the only patient I've got
Can you get
right coronary
LEVO
compression
cordon?
in was a post-Ross
Yes,
with
of course.
translocation of the
circular.
coronaries at the time
It's
of
a
surgery,
risk of coronary
Little more
compression.
but not
Yeah, we have seen in only those patients with coronary abnormality or any transfer of coronary, such as
Yeah.
Nikaido or.
Yeah. So
we-
Shiva,
we-
that
we
looks
haven't
really
seen.
good.
So we gave up to use coronary compression test in native alveoli because we put a stent with a
Echo-large.
radial force, but we do semi-compliant
Echo-large.
balloon during the coronary
Make it ice
compression
cap.
testing. So even if you
Color.
you don't see any coronary compression with balloon, but
Keep it in the center of the well.
self-expandable stent
Shiva.
with a radial force.
Increase the color
will
width.
cause.
Yeah.
Shiva,
Yeah, tell
on
me, Shaq.
echo currently, what do you think? Because it looks as if whatever the shadow was that we were looking at, we don't see it on this view.
Yeah, well,
Is
I
that
mean, right
correct?
now the pulmonary regurgitation seems negligible. Now take it out, Alka. Go on a zoom on the valve.
I think it
Go on a
is
zoom on the valve.
trace amount of regurgitation, no significant regurgitation. Maybe
little
like you
larger.
limit should be increased. Yeah.
I think you've got a superb result,
Yeah.
Shiva.
Very good.
Jack, have you seen halt
Color?
after these?
Seen what?
Halt phenomena
Trace
in
amount
this?
of regurgitation.
So,
Halt, by the way, is hypoattenuated
Color out?
leaflet thickening, and that can sometimes simulate like there is a thrombus there.
yeah. So, not acutely, and we had one patient about 2 or 3 months later with leaflet thickening. So we treated it as if there was microthrombus formation with heparin, and that got rid of the gradient. So it can
Color?
happen.
Shaq, let me share with you our experience on venous P valve thrombosis. We have 2 patients where,
thrombosis.
Shaq, can you hear me?
Yes, I can hear you very well, but Warrican was trying to make a point about some thrombus
Okay. Okay.
formation.
Yeah, so with that we admit the patient giving heparin and then giving dual antiplatelet, and so far the patient is doing well. The gradient drop,
Yeah.
like without any further
So-
management.
Shiva, what were you trying to say now?
2 of our patients who discontinued aspirin and clopidogrel. Our protocol is lifelong dual antiplatelets with aspirin and Plavix. However, a couple of patients stopped them, and on a routine surveillance CT at the end of 4 years, we found some amount of leaflet thickening on the basal part of the valve on the pulmonary side, like at the nadir of the sinuses. So in those patients, we started them on aspirin and plus Coumadin, and we are planning to repeat CT after 6 months to 1 year. The question about Zahid, I think there are tiny air bubbles which are trapped in the pulmonary valve leaflets, which gave that mobile appearance. You see here now also, there is an air bubble that is getting trapped in the pulmonary valve. Because the patient is in lying position, it is getting trapped in the pulmonary valve. Do you think so?
Well, I'm not sure about that, but I hope you're right for the patient's
But
sake,
you
to
see
be
that
honest with
they're
you. I mean,
moving,
you see
Zahid.
that the material is definitely more distinct than the leaflet is.
Have you checked the ACT, Shiva?
We have sent it, Shaq. We are waiting for it. Shaq, I think it's not, it's moving too much, Shaq. So I think it's an air bubble, probably a micro air bubble, which is very powerfully illustrated by the echocardiogram because of the reverberations.
Well, then you could do another angiogram in the right ventricle, and that should move it.
Okay, so basically we have a very interesting pseudoaneurysm of Takayasu aortoarteritis in the other lab. So can I shift over to the other lab while Pramod will get a figure of 8 here and proceed further here? Can I move to the other lab?
A big round of applause to the first case. Thank you. And while you're moving to another lab, maybe I ask Ajahn Pavit